Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a very hard cataract with weak zonule. Let us observe this surgery. After making the incisions and staining the capsule with trypan blue dye, capsulorhexis is being done at this time. At this time, the zonular weakness didn't appear too much. But the nucleus is very hard and the pupil has not dilated well. So I am doing a rhexis as large as possible. It is about 5.75 millimeter rhexis. Hydrodissection is done very gently, and I don't try to rotate the nucleus by the hydrodissection cannula itself in such cases. In such cases, always inject visco and then rotate the nucleus bimanually. I repeat, rotate the nucleus bimanually, and this will reduce stress on the zonule. Yes, this will reduce stress on the zonule. So bimanual rotation of nucleus is very important when you have detected zonular weakness. And now the patient is under topical anesthesia, so I have to be extra cautious. Any moment the patient may move his eye or head, and I have to be very alert, extra alert in this case. This is my submarine chop technique. Bury the tip of the Phaco needle into the substance of the nucleus and make a nice crack. Now I rotate the nucleus and make another crack and then rotate it little more and make one more crack. So one heminucleus has been divided into 3 pieces. At this time I find that the nucleus is not rotating nicely. So what should we do? I am trying to remove one nuclear piece. I am tilting the nuclear piece, getting onto the apex and pulling it at the central part of the anterior chamber and getting another piece and emulsifying this. And now this half rotates easily. This is another good crack, but the piece is not free, it is still attached at the central part. Rotate it, make one more crack. This is the time we should be very cautious. We may catch the whole bag, we may cause PC rent in such cases. I am trying to keep the epinuclear shell and pulling only the nuclear part. So the epinuclear shell is protecting the posterior capsule to some extent. And this is the last beat of the nucleus. At this time I have reduced the vacuum and flow rate. Till now it was 400 millimeter of mercury vacuum and 40 ml per minute flow rate. Now it is 250 vacuum and 25 ml per minute flow rate. Ultrasonic energy used is 70% in this case. And now this epinuclear shell is to be removed very gently. Yes, the posterior capsule is intact, and at this moment I am happy. But see what happens in a few minutes. There's a small nuclear piece which was stuck into the side port. First thing we should do is remove this nuclear piece. And now see what happens. The whole bag tends to come out. But since I am using a Simcoe cannula, I can immediately respond immediately, and I can flush out the caught capsule. And now is the time to apply a CTR. Without applying a CTR, we can't proceed. So the leading end goes into the capsular bag. Gradually the CTR goes in, and now I hold the trailing end of the CTR, use a Sinskey hook to place the trailing end in the capsular bag, and now the CTR has taken its place in the equatorial part of the capsular bag. And now I am trying to remove the cortex. But whenever there is a CTR, removal of cortex is not easy. However, with some patience, we can do it. So what I am doing is I am getting onto the cortex and pulling it tangentially, circumferentially, not centripetal pull. It is a tangential, almost tangential pull. And now I go through the right side port and remove some cortex from the upper part. Now I go through the main wound again and remove some cortex from the 7 o'clock, 8 o'clock area. And now is the time to implant an intraocular lens. The capsular bag is filled up with visco, and a single piece monofocal aspheric intraocular lens from Johnson & Johnson is being implanted in this case. This is Technique 1. I like this lens very much, probably one of the best intraocular lenses in the monofocal platform. The lens is nicely placed in the capsular bag. Visco is removed. Visco cleaning has been edited. I took about 2 minutes to remove the visco, went behind the intraocular lens, and then hydrated the side port, and this is the final lavage of the anterior chamber and formation of SE with Simcoe. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.